Okay, thank you. It's a pleasure to be here today and to talk to you about the work we've been doing. It's about the co-development adaptation of KOKU. As Sabine just said, short for Keep On, Keep Up. And I'm joined by Jahida, Babusha, Yamin and Charlotte. I must mention that Babusha's calling in all the way from Nepal and Yamin from China, which is fantastic. So if there's any issues with the connection, just give me a shout. And yeah, we've been working on this development for a few years now, and we just want to share a bit of the learning. It's a medley of a talk, so you'll get little snapshots of lots of different pieces of work. And at the end, Charlotte's going to talk a little bit more broadly about the policy context. I just want to acknowledge the funders to start. We are currently funded by NIHR England for a randomised control trial and an implementation study in Greater Manchester, and Innovate UK have funded most of the development. But we've had smaller pocket bits of funding from other funders, like in Health Innovation Manchester, which has been really important because it is difficult at times to get that continual funding that you need with digital health development. Also, the wider team, we've got a fantastic wider team and collaborators. So we work with Later Life Training and Reason Digital. And also, lots of participants have been brilliant all along the way, feeding into, the different adaptations and developments. The reason why we went down this road, why we were so interested in trying to do something to prevent falls, is this, as you can see in the headline here, that falls are the leading cause of injury-related death in older people. They're incredibly common. So 1 in 3 over 65-year-olds fall each year, and that risk just grows as people as they age, and nearly 50% of hospital admissions for injury are due to falls. So very common, incredibly costly. We know that they're costing, the most recent figure is 4.4 billion to the health and social care services. Now, not every fall results in an injury. About 10 to 20% do. Those that don't result in injury, people are still left with like a psychological impact. So they tend to then not go out as much, become more sedentary, and that increases the risk. So the consequences are high, even if they don't have some of these more serious issues. Of those that do have an injury, a hip fracture is one of the most common serious injuries, and the outcomes are really poor from those as well. So we know that 30% of people die within a year, and 50% never regain their former levels of mobility. And you'll be aware as well that lots of our older adults, they were more deconditioned during the pandemic, and this deconditioning, it hasn't gone back to normal just yet. It's improving, people are becoming more active again, but it's not quite got back to the pre-pandemic levels. And that deconditioning, it's not just the physical decline and functional decline, it's that psychological decline. So we're looking at needing to do some holistic work here to try and target this massive problem. I know in the PANCA seminars that you've already had lots of discussions and talks and great research about digital inequity. So this is another area that we obviously have been working on, I'll share more about as well. But these are things that really did become more apparent from the pandemic and the current situation. Better news is that there's incredible evidence now, really strong, robust evidence that strength and balance exercises are the most effective intervention to prevent falls, and they can reduce around a third. Not all are preventable, but that's still a high proportion. And we've got hundreds of randomised control trials that have specified the types of exercises, how they need to be progressive, and other recommendations more widely. And so we've used all of this evidence and we've embedded that into a digital programme. It's not meant to replace the health or social care professional. It's meant to supplement current services, or to fill some of these gaps where we know people are not getting physio or healthcare support, or they live in rural areas, and those kind of gaps as well. So KOKU, we developed with older people. It's got these specific strength and balance exercises, the Otago FAME exercises, and we've added health literacy games as well. And we've embedded some health behaviour change techniques too. The overall picture at the moment from the research, it starts, as you can see on the left. We did lots of user-centred design work, so focus groups with over 100 older adults. We did iterative testing, so we took the feedback from those people and kept improving and adapting KOKU according to their needs. And that's quite interesting, because a lot of the design principles with the software developers that they base their work on, they don't quite fit the needs of older people. And I'll mention a little bit about that in a minute. So they in themselves are an underserved community. And then taking when that got to the point where people, were happy with what we were doing, we took that to these usability, acceptability, and feasibility studies. You can see the early evaluations in the centre. We've had 4 mixed method studies completed, 2 in the UK, 1 in Texas in the US, and 1 in Trondheim in Norway. People use KOKU independently for 6 and 12 weeks. And what's interesting from that side was that these are independent teams, but the results were consistent, and that there were high levels of acceptability and usability, and we found that people frequently talk about how easy it is to use. And now we are working, we're halfway through an implementation study across Greater Manchester, and we're just about to start a randomised controlled trial, and there's another RCT in Germany that's underway. And this slide, I was thinking about what would be useful for the listeners, and I was thinking that, in our group, and maybe this is more familiar to people that are listening in, the Medical Research Council for Complex Interventions is our go-to, guidance for developing any type of health intervention. But with digital interventions, there's other areas that need to be considered. And this is some learning I took from CIMIT, which is the health arm of MIT. I spent a little bit of time over there a few years ago, and have helped to support other people developing health technologies. And you'll see in the centre, you'll see some of these areas that aren't really covered traditionally in the development of complex interventions. So yes, you need your clinical evidence and the underpinning evidence in the early development, and you have to evaluate as you go along. But there's a market and business awareness that's needed. Regulatory requirements, and you need the technical support, which is very costly to get technical input, as you keep, that doesn't stop at the end. You need to keep these digital interventions up to date. And then you can see the 10 standards around the side that take you from the need, the proof of concept through to a full implementation and scale up. So going back to our users, from the start, as I said, we worked with over 100 people to make sure that what we were doing was based on their needs and their, what they could work and how they could, manage using a digital intervention. And they were as young as 55 up to people over the age of 100, and so very diverse members of participants. And then we worked with our later life training, who are experts in training for older adults. I'll just show you. This is Bex Townsley, an exercise instructor, and she's showing you how to correctly, even just to get ready to exercise, to stand up from a chair. She's pedaling her feet because that stops postural drop and gets somebody ready to exercise. Because our users, they're not the people that would perhaps, be able to access a physio app, online. These are people who are pre to moderately frail, don't tend to use digital interventions, may have smartphones and things, but not really use them other than to communicate. So we've made everything very simple, and you can see the character there is he's a little bit on the round side. He's there's bright colours and contrast, and all that came from our user development and user co-development. When people download KOKU, it teaches them how to use it, and each time they don't get the same questions each time. Once it's personalized to each user, then they have their own program. And we have these 4 descriptors, so that when they add a bit of information about themselves, they can choose the descriptor that best suits them, so that it fits their level of ability. And it's a 12-week structured strength and balance program. In addition to that, we've got these health literacy games, and we're expanding these at the moment. Some of the members of the team will talk about these. I think these have been really, really fun for people. You see people immediately when you start playing these games, they start laughing, and some bits are really easy, other bits are a little bit more challenging. This is a home safety game, and they just click on, the rug and the cat and things, and then the evidence, is based on, again, Cochrane reviews about what are the main home hazards that can be modified, and then it gives them instructions about what to do. So really simple, but a lot of underpinning important messages. And then you can see here, this is like a home page for a user, and we've got large icons. Even some of the icons we had to change because people don't understand what they were, and made it as simple as possible. And then I mentioned about gamification and health behaviour change techniques. This screen just shows progress, and those green ticks or white ticks on a green background, if I'm more precise. They help people to see how they're progressing. There's nudges in there to remind people to use it, and lots of positive feedback too. Across Greater Manchester, we put an expression of interest out last January, and we had 102 people respond to that single request. And we're now working with 26 providers across the 10 localities. You can see in green, those are people that are up and running. Some people were able to just get up and running and start using KOKU within health and social care. And there's charities as well currently using it. Others, it took a little bit more of setting up. We've been able to support them with purchasing iPads and providing them, ourselves as well. And then, the red are people that were still in planning stages. But we had such a great response. And then we did a smaller sub-study where we looked at, this is during the pandemic, by the way, the COVID pandemic, where people were unable, we couldn't go in and do some of our strength and balance tests, but we could do some self-report type tests with people. And we had 47 recruited, and we used the carers, we trained carers online, and then they went into the older adults and helped set them up using KOKU. And after 12 weeks, we were then able to repeat the measures, and we found that fear of falling was significantly reduced, and the reduced level of frailty, the Rockwood frailty score, went from mildly frail to very mildly frail, and that's a really good outcome. Now, we had high levels of depression from these particular users. Again, I think that reflected more what was happening at the time with them, being in lockdown, and that reduced. It could be, just the interaction with the carers, but there were fewer signs of depression after 12 weeks, and we saw higher quality of life, improved physical activity, improved pain and fatigue. And you will see these types of great improvements because exercise is such a fantastic intervention, and there were no adverse events. I've summarised some of the areas that we've worked on, again, that the rest of the team will maybe talk about. On the left are the issues that we have to really consider and try and do. We can't make something that works for absolutely everybody, but we can certainly target some of these areas with digital interventions. So what we did with KOKU is we started off with an iPad version, iOS version. Then we had to raise the funding to make sure it was on Android as well, because more people can afford some of the Android devices. We've worked with digital inclusion teams to be able to either loan and train people how to use iPads, or they help to fill in forms, so that people can get this government grants to actually enable people to have their own device, which is great. We've worked with care providers too. So again, training them up, they then cascade the training to other people. And some of that training isn't just about how to use KOKU, it's how to use a tablet or an iPad, and what the messages should be, to try and encourage people that might be a bit fearful of technology or fearful of doing exercises for whatever reason. Further down, you can see, I talked about how simple we've made KOKU, again, through testament to our users. No jargon, high, really focused on ease of use. And then we've looked at, we haven't just looked, we've now developed it into different languages and made some cultural sensitive changes into Urdu, Mandarin, Danish, Spanish, and other languages as well. And here we've got a couple of examples of the changes, just going from English to Urdu. And now this wasn't trivial, this was actually quite complicated. And it's not just because of the text size changes, but also because there's different words for different say foods or different expressions, and we wanted to make sure that it was friendly, not too formal, and just getting that balance right was quite tricky. We changed some of the characters' clothing and took out things like alcohol in the fridge and removed the pork and meat from some of the games. So you can see here there's changes between the left and right. In the home hazard game, we've removed the cat because that wasn't appropriate for some of the communities that we were working with. Even things like the picture on the wall, they said no, we wouldn't have a big picture like that of a family member. We would have something like a scene. And so there's all these small subtle changes, but important to some of the communities we've been working with. And then here you can see the iteration. So at the bottom there, even when we thought, yeah, we've cracked it, we've got these new foods in the fridge. When we went back and said, look, these are the changes according to what you said, they were like, well, no, actually the colour's not right, and we wouldn't package foods in plastic like that. So lots of small but ongoing learning here. Now, all of that user testing and support from them has meant that when we were evaluated by ORCA, who are the largest health and social care app reviewers, they've given us really high scores, which is great. And we've worked with NHS Digital too, and it means that KOKU is classed as NHS approved and can be used out in practice. An NIHR review of all different types of strength and balance apps worldwide had KOKU as one of 4 that were recommended. It's the top one in the UK. And we've got some more, I mean, there's lots of, more detail and data and things. We've got this data dashboard that's now set up, and we use Google Analytics that we're just pulling off. But there's more information here on some publications if you'd like to know more. So that's everything from me. And I'm going to hand over to Jahida next, who's going to talk about the dementia friendly version. Thanks.
Thanks, Emma. Hello, everyone. I'm Zahida Ganganagari-Palli, and I work with Emma and other members of the team. So I'm going to talk about KOKU Lite, so the modified version of KOKU for people with dementia. So, oh, Emma, yeah, sorry. Next slide, please.
It's got a bit stuck. Hold on.
Okay.
I'll go out and in. Won't be a second.
Right, thanks, Emma. Why KOKU is needed for people living with dementia? So yeah, let's go on. So it's underserved group. Why is it underserved group? Based on NIHR include, people living with dementia is considered as one of the underserved groups because they are digitally excluded, they're cognitively impaired, and also some of them, lack capacity to consent for themselves. So what evidence do we have for? Some of it Emma has already covered in the previous slides. So 1 in 4 older adults aged 65 and over experience a fall each year. So, but 1 in 2 older adults with cognitive impairment or dementia are likely to fall each year. And 1 in 5 falls causes serious injuries, like again Emma said, head injuries, broken bones, etc. And falls are estimated to cost NIHR over £4 billion annually. Thank you. So let's look at what technology do we have out there. So there are different types of technologies to help people with dementia from diagnosis to improve their quality of life. But for technologies to be acceptable, like Emma was explaining, so it has to be well designed. So, for example, using agile methods, including collaborative approaches and iterative testing, etc. And especially has to be co-produced with people with lived experiences, in this case, people with dementia. So next slide, please. So the KOKU Lite. So can KOKU Lite help? That's what we wanted to find out. So a previous work with KOKU, as Emma was explaining all the benefits that it has. So from the clinical trials in the UK and USA, it has shown to reduce falls per third through proven strength and balance exercises and the health literacy games that it has, including hydration, bone health awareness games, and home safety, and all those like Emma was showing. And so we modified the current existing version of KOKU for people living with dementia to suit their needs and make it dementia friendly. So that is what we are calling it KOKU Lite. So we have completed the co-production process. So just now we heard that for the feasibility or randomized controlled trials, we got a favorable ethical opinion to go ahead with our feasibility RCT. So which I'm very, very grateful. And then, going on to the definitive trial if successful. So how we did the co-production with people living with dementia. So this is a 3-stage process. So stakeholder consultations. So we have consulted people living with dementia, and then we also conducted focus groups, and then we also did one-to-one interactions with people living with dementia. So, and then we got valuable advice and what features to remove, what features to add, and then simplify the language, the jargon, the terminology, and what. So we had loads of feedback, very valuable feedback that we received from our people. I mean, from people living with dementia and their carers. So for this, what we did, so to inform the stakeholder consultations, so we had to build relationship with patient organizations, which was very difficult initially, but it went on. Eventually, it got really better, and then so we have strong established collaborations with patient organizations, and then we formed project advisory group with 4 members. With lived experiences. And then we also prepared content to inform the stakeholder consultations. Now, after this, we received lots of feedback. So we had to discuss within our team. So we had discussions within our team, and then with the project advisory groups, and then recent digital software company. And we discussed the content and agreed on what features actually to take on board. And then we refined the content. So, and then we went on to test it. So from the early testing, so we wanted to really find out whether the modified version of KOKU, that's called KOKU Lite, whether it is acceptable to people living with dementia. So yeah, to summarize, this is our co-production process. So what are we planning next? So future work. So development of brain health game, which is underway. So actually, we had planned for 3 different games. But again, our PPI representative, wonderful PPI representatives, so they have advised us of the one it's displayed here. It's a matching pairs game. So brilliant feedback. And then we considered, and then we went on to develop the brain health, the matching pairs game, which is in the final stages now. So it will be out there soon. So for the brain health game, the next steps are going on to the feasibility RCT again, going for the ethics for us to be successful, and then going on to the definitive trial. So, and then the long-term plans are for us to modify KOKU Lite for people with dementia from South Asian communities. So what did we do thus far? So we built relationships, and then we are exploring further relations. Then looking for potential opportunities, get some funding, secure some funding to kick on the work with South Asian communities. So I think that's it for now. I'm going to stop now and then to give the opportunity for others. Thank you very much indeed.
Thanks, Jahida. So we're now going to go to Babusha.
Okay. Hi, thank you so much for giving me the opportunity to present. I am a second-year PhD student. And today I'll be talking about a scoping review and a systematic review that was done to look at the experience, attitude, and effectiveness of digital health interventions for older South Asian communities. Oh no, what's happening with this slide? This is just a disclaimer that I'm required to present. Next slide, Emma. So why South Asians? South Asians are the largest minority population in the UK. They also have 6 times higher risk of diabetes compared to other population, and they also have higher risk of heart disease compared to the national average population. And to top that off, they have lower physical activity, which puts them at lower physical function, lower health outcomes, and a higher risk of falls. And Emma, as discussed earlier, the risk of falls is, it puts the population at risk of injury and disability. So to make sure we address the specific health needs of the South Asian community, digital health interventions could be one of the tools that we could use. And to understand that, we needed to understand the South Asians' experience and attitudes towards digital health interventions, so that its barriers and facilitators are known. And this scoping review was done by Nasar Al-Dosari, and it was done in a global context, which looked at all healthcare settings and aged 18 and above. And nearly 20% of the world populations are South Asians, and there were only 15 studies that met the inclusion criteria. Next slide. So the findings were thematically organized based on barriers and facilitators. And South Asian population, they face a lot of socioeconomic and cultural like factors that puts them at a risk of having less time to develop skills related to English as well as technology. There's also a mismatch between user needs and design because the context really varies. In the scoping review, one of the studies was in India where people preferred to have digital interventions, but they wanted voice instead of text because text was related to literacy and English skills. Whereas in the US, they preferred for in-person interactions over web communication because web communication required English skills as well as technical skills. And the more people were concerned about the data misuse, the lesser they wanted to put in their health information in the digital health interventions. Also, there is for cultural sensitivity, there was also this belief that using digital health interventions could take time away from spending time with family and social interactions. And gender roles also in some communities they required the female members to get permission from their male family members, whereas in some communities, female members actually knew more about the digital health interventions than male counterparts. For facilitators, generally, like if the more social support there was available, specifically if there was younger members that were involved, then older members were most likely to use an uptake of the digital health interventions. But then there's also this catch that it could relate to more dependency on the social support. So we had to develop parallel systems where there's social support to help people use digital health interventions, but also make sure that we encourage independent use so that people are motivated to use digital health interventions for their health outcomes. And then also using familiar and like gathering places to provide digital health interventions so that it's accessible as well as acceptable. And as discussed earlier, there's already a very small time limit for people to learn new technologies, so making sure that the technologies are simple to use. And cultural preferences for end users. So South Asian population, it's almost like people from ethnic background of 8 different countries like Nepal, India, Pakistan, Afghanistan, Bangladesh, Bhutan, Sri Lanka, and Maldives are categorized into one specific category, and it's very diverse. Some languages don't have written form. So making sure that we involve the population that we want to target and ask them what is their preference in terms of language for the intervention. Next slide, Emma. So this led to the systematic review, which looks at the effectiveness of digital health intervention, and it's focused on physical function for South Asian age 50 and above. This was also a global systematic review, and one of the main criteria was we wanted to make sure that the studies that we looked at had a clear demographic category of age 50 and above listed in the studies so that we could tell that the intervention that was discussed in the study is actually effective for older population age 50 and above. Next slide. And while doing that, there was only one study that had all the criterias, and it's a small RCT study done in Pakistan with 90 subjects, which looked at people age 60 and above. The intervention group was a WeFit exercise, and the control group was balance training exercise, which was done twice a week for 8 weeks. And in this one, the results showed that the intervention group, the WeFit group, had better outcomes in terms of gait, but then there was not much significant difference between intervention and control group for balance exercise. One interesting thing was people using WeFit were more motivated to exercise, but then this is a small study, so you have to take it with a grain of salt. Next slide. So there is really a need to create digital health interventions for South Asian populations, and we need to make sure that there's clear age category for 50 and above. So it's not just 50 and above, but having 50 to 60 like clear categories, and also making sure that there's clear categories for ethnicities that are involved in the study. And while we design the interventions and test interventions, we need to be intentionally inclusive of the people that we are including in the study, because context really matters. Next slide. Because context matters, because people's identity is their superpower and not their obstacle. Thank you so much.
Thank you, Babusha. Now we're going to move on to Yimin.
Hi, everyone. My name is Yiming, and I'm here to give a brief introduction about the research project I'm currently working on, the Chinese version of KOKU. Next slide, please. Yeah, so here is some background information about why it is important to look at the UK Chinese old population here. So according to the Office for National Statistics, in 2011, so the number of older Chinese over 65 years old is 19,027,275. And according to the new data, the Office for the National Statistics in 2021, the number of older Chinese people aged 65 years old is now around 38,000. So we do increase a lot of people here, older Chinese people here in the UK now. And in the literature, the UK Chinese population sometimes can be described as a very hard to reach group due to many reasons, such as geographic distribution and also language barriers. And in the reality, it is more difficult to approach to the UK Chinese older population because they have very limited access as to the digital technologies and also other information. So that's the reason in this context, although the use of digital health technologies could be a very possible way to prevent the challenge of aging, we still need to face many challenges, and it is quite a common phenomenon that in many countries, so older people usually lag behind younger people in their use of digital technologies, especially for those whose first language is not English and for those who live in the rural areas. So that's the reason why in our research, we are aiming to work on this Chinese version of KOKU to support more Chinese older adults to interact with the digital health technologies. Yeah, so this slide is because currently we are working with the NIHR China and also the Beijing hospitals in order to get more evidence related to how to support Chinese older adults using digital health technologies. Next slide, please. So I currently did a qualitative study. I use a explorative qualitative approach to understand older Chinese adults' experience in using digital health technologies and also their feedback related to the Chinese version of KOKU. So a mix of focus group and individual interviews have been conducted, and currently a total of 26 older Chinese adults living in community settings in Manchester have been interviewed, and the eligibility criteria for those participants are older Chinese adults aged 55 and above, and they can speak Mandarin, Cantonese, or English when they take part in the interviews, and they have a Chinese origin but not born in the UK. From the left hand, we can see here are some pictures. So during the interviews, I gave a quick introduction about the KOKU and give them the tablet. So when they interact with the KOKU, I will observe them how to use it, and then will ask their opinions related to the use of KOKU. Next slide, please. So here are some key findings of my current qualitative study. So one aspect is about the digital experience. So first, some Chinese adults, they still have conflict feelings on the digital devices. Emma, can you move back? Yeah. Yeah, so they still have conflict feelings on digital devices. So One male aged 83 years old said, I think people who know how to use electronic devices are so good. If I don't understand, I will ask them. If someone teaches me, I'm happy to learn. So they use very positive words like so good, happy to learn. But another female aged 80 years old said, sometimes I feel unsafe and insecure in using digital health technologies as it's difficult for me to use them correctly. So here she used the word like unsafe and insecure and very difficult for her to use the technologies. The other aspect I want to talk about is the cultural differences. So we noticed that there are the older Chinese adults living in the UK, they still retain lots of like traditional Chinese habits. For example, they have very different exercise and eating habits. So some of them, they will do the Tai Chi and like eating traditional Chinese food, such as rice, noodles, and dumplings. And so although this is very small, like simple things, but it do change quite a lot when they are using the KOKU because sometimes they can't recognize the package, the food in the games. So this is one aspect. But after we analyzing all the interviews, we'll have more comprehensive picture about that. Next slide, please. Yeah, the other aspect is about the accessibility and usability of the Chinese version of KOKU. So we analyze this theme based on the EAST framework, which is developed by the Behavior Insight team. So here are some examples. So the first sub-theme is about whether KOKU is easy to use among the Chinese older adults. So one female aged 66 years old said, I think KOKU is very easy to use, and the color, contact, and functions are also good. I like it. The other aspect is about whether KOKU is acceptable among the older Chinese adults. So one male aged 82 years old said the animation makes the app more interesting to play with. So these are very positive feedbacks, and they still give us many useful feedback related to how to change the KOKU to meet their needs and preferences. Again, so we will update this theme after we finish analyzing the interviews. So next slide, please. So this is a layout about how we change the KOKU from English version to the Chinese version. So although currently we only change the language part and also the voice part, but still we can see it changed the layout a bit. Next slide, please. Yeah, so in the future, we are going to continue interviewing more old Chinese adults who are in the early stage and middle stage of frailty, because compared to the healthy ones, we think currently Chinese version of KOKU is more suitable for the older adults who are in the stage of early and middle frailty. And also we will adapt the Chinese version of KOKU based on the older Chinese adults' feedback. Yeah, thank you.
Thank you, Yumi. Now we've got
So I'm going to finish today's seminar by giving an overview of some of the work carried out across the Older People Frailty Policy Research Unit and the ARC GM Healthy Aging team, giving a wider context of some of the policies around the work and why it's important to be doing the kind of studies presented today. So just a bit of background. The World Health Organization has been encouraging the use of digital technology to improve health and social care services for many years now. And in 2005, they urged members to promote equitable, affordable access to the benefits of technology. That's translated into the current strategy, which has an outcome focused on the development of human-centered health systems and empowering people to make healthier choices. We also know that the NHS, the government, and other health and care bodies are pushing towards the digitalisation of services. And in Greater Manchester, the Mayor's Manifesto includes an aspiration to get all under 25s, disabled people, and over 75 years online. So there's a wide range of push factors across the board, moving towards greater digitalisation and use of technology. But what's less clear is how this is affecting older people and people from underserved groups who may experience greater barriers to the use of technology. So the first piece of work I want to talk about was undertaken in the ARC and completed in 2 stages. The first stage was to conduct a rapid evidence review that looked at major recent academic literature and a range of reports about digital technologies and older people from major organisations like the Centre for Aging Better, and the Good Things Foundation and the King's Fund. I'm not going to talk about the review today, except to say that we spotlighted the impact of digitalisation in three key areas: healthcare, financial services, and public services. And some of the top line insights are on the slide here. But there's more information in the report. One of the key things we did was to look at the statistics on the internet use among older people. Most of the evidence is from before the COVID-19 pandemic, or right at the start. But in 2020, the most recent ONS figures, which actually broke usage down into small enough group age groups of 65, showed that older people were still more likely to be digitally excluded than younger age groups. And despite increases, nearly half of people aged 75 and over haven't used the internet in the last 3 months, and over a third have never used it. Leading on from this, we conducted interviews with older people, specifically aged 75 and above, and we tried to conclude a range of users, lapsed users, and non-users of the internet. We interviewed 24 older people, aged 75 plus, and 2 community support officers about their use of the internet. A number of themes emerged, and some of the key ones relevant to today were, firstly, around the motivation to participate digitally. As these interviews took place during the pandemic, the initial motivation was often to do with keeping in touch with friends and family and maintaining that connection with them. Theme 2 related to digital participation and well-being, and several participants said they didn't want to do everything online because they like to get out and meet people and get some exercise. So there's always a need to consider the impact of digital technology on other policy ambitions. And thirdly, amongst some participants, there was a feeling that they may be the last generation to experience this exclusion. We know that technology is always moving forward and there will always be new innovations which can leave people behind. So this actually may be more about feeling the technology is not for them or not designed for them. The second piece of work I want to talk about was a mapping review, looking at the evidence around the digitalisation of health and care services during the COVID-19 pandemic, which we know pushed on digitalisation. An important aspect of this work was identifying the extent to which factors related to health inequalities have been considered during the evaluation of digitalised services. This review wasn't aimed at synthesising the evidence produced, rather it is about mapping the landscape of the research. So these are our inclusion criteria. There were older people who looked at any form of digitalised health or care intervention, and we looked at any studies that had an outcome of any sort. We used the Progress Plus framework to ascertain how far factors relating to equity have been considered. When we applied the Progress Plus framework, we could see a lack of focus on factors relating to equity. And I'll use the UK studies to exemplify this as we report to UK policymakers. So we looked at which studies had recorded any information about any of these characteristics. All of them had age, as seen here, because that was one of our inclusion criteria. But not many had recorded information about other characteristics. And what's more interesting is that even fewer had actually done anything analytical with the information we collected. And that's important because it shows that even though we know how important these factors can be, they're not really being considered in this type of research. There are some follow-on pieces from this looking at minoritized ethnic groups and access to GPs, but that's all on the website. I'm not going to talk about that today. So the final piece of work I wanted to touch on today was a rapid review of reviews looking at the use of digital technology to reduce falls in people living with dementia and non-cognitive impairment. So this was a rapid piece of work undertaken to feed into the government's proposed 10-year dementia strategy, which has subsequently been merged into the proposed long-term condition strategy. You can see our inclusion criteria here on the slide. And after screening on full text, we ended up with 7 systematic reviews which met our inclusion criteria. So the main types of technology we expected to find evidence around were wearable technology or sensors, environmental sensor-based systems, exogaming, virtual reality systems, and apps. But we were open to finding any other types of technology as well. As the use of technology is increasing, we expected to find a fair amount of evidence of people living with dementia and non-cognitive impairment. But what we actually found and no more than 2 reviews for each identified technology, and no reviews around apps for fraud prevention in older people living with dementia. We found limited evidence, and most of the reviews were based on small studies with weak methodology and short follow-up periods, which means that the evidence isn't robust. We don't know if any of these technologies had longer-term impacts on kids. A lot of the evidence was incorrect, meaning that the studies included in the reviews didn't directly measure falls, but instead measured other outcomes, such as balance and posture. And whilst these can help to predict falls risk or develop new technologies to reduce falls risk, they don't actually tell us about the direct impact of falls. Also, although we know that people living with cognitive impairment could possibly benefit from these technologies, they're often excluded from the development and testing phases. Some evidence show that people living with dementia can find these technology systems unsettling, and they may become distressed or refuse to use them. So it's important to consider users when developing these technologies. None of the reviews included in our review reported on whether staff, users, or carers are getting involved in developing the technologies, nor any on consideration of the wider context when implementing the technologies. So although digital technologies may have the potential to reduce falls and falls risk for older people living in cognitive impairment, the effect of the technology is yet to be established. And we found insufficient good quality evidence at this stage to recommend which technology is best placed to be used. So the repercussions of this exclusion and lack of consideration for some users is far-reaching. It can widen the digital divide, exacerbate inequalities, and restrict access to critical resources like health and care services. And if we're to create a more equitable digital landscape to bridge these gaps, we need an emphasis on user-centric design, involving older people and people from underserved groups in the design and development of new technologies to enhance usability, accessibility, effectiveness, and desirability, and allow as many people as possible to benefit from the introduction of this technology. By involving older people and members of underserved communities in the design process, we ensure that their perspectives and needs are at the forefront of technological innovation. The benefits can be huge. Tailored technology not only enhances accessibility, but also fosters independence and empowers people to live longer, independent lives, creating a more inclusive and equitable digital landscape. So obviously, with time being limited today, I've only been able to give you a flavour of some of the work we've been doing. But if anyone's interested in finding out more, all the reports are on the Older People and Sales Policy Research Unit website or ARC-GM website, along with the full list of team members. And we have 2 papers which are about to be published with further details. So thank you, and if anyone has any questions, I'd be happy to myself or any of the rest of the team happy to answer those. Thank you.